in the way we have done the NHS before. And of course, the whole wheel of life that we have to do. The other bit that as CCGs we have to look at is cultural diversity, because the diversity, you cannot have one care pathway for everybody. There are other ways of, because we are individuals and we behave differently. And unless we're looking at the wider determinants of health, they will cause us problems. So if we do not look at loneliness, we don't look at social and supportive networks, we don't look at mental health, this is going to be a problem for us. Because that is cheaper to do, it's much more expensive once people become ill and isolated. And so we have to prioritize differently. So you will hear a lot about cost improvement plans. What is your cost improvement plan? 3%, 4%, 5%, a lot, on top of SIP. We have to convert that cost improvement plan of taking stuff out into a community investment plan. So it's a mirror image of SIP, but it's a community investment plan. And our plan is 14, 15 onwards, we invest heavily into the community, taking stuff out of acute care where it's the wrong place to be. The other bit is around health inequalities. This is very stark. This is done work I was part of a health inequalities work group with a DH. So the red terrier, who seems to be vomiting or doing something, the red bit is where people with cardiovascular disease are on a register. Yeah? And on this side, the red bit in the middle, on your right side, is where the people are dying of cardiovascular disease. So that means there's a mismatch between people on register and where they die. And when you put health inequalities over here, it fits in exactly with where the health inequalities are. Where deprivation is, people are not on a health register and are dying, and we need to go for them. So that's where the public health observatories and others will help us to identify where we should focus our attention, because we tend to focus on the places where middle-class people live and shout the loudest. That's not where we need to go. So what's our Crawley CCG about? How am I doing? How much time I have? I don't have a clock here. 15 minutes. Okay. I'll speak quickly. So Crawley CCG, they're triple aims. And these are broad aims: improving the health of our and the well-being of our population, improving our patient experience, and reducing our cost of care. We have to do all three, not one or the other, because that's the way the economics is. And that's what's expected of our commissioning outcome frameworks and everything else we have to report up. But it fits in really well with the triple aim in the Constitution or the bill, putting patients at the heart of the NHS, delivering improved healthcare and outcomes, empowering local organizations and professionals to improve quality. This is about localism. And this is where things change away from the SHAs, PCTs, and what has been before. And if you look at Crawley, that's where this place I know, we look after 130 because the census is out and we've got 6,000 more patients. 50 languages, 13 practices. But that's not very different from a lot of boroughs in London. Yeah. But if you take the number 10 bus from Broadfield North through Tilgate, you get 1 year. You go through Furness Glen, you get 3 years. You get to Pound Hill, you get another year. You don't have to sit on the bus to do it. It's, you have to live there. But if you take a right turn at Three Bridges and went into Maidenbower, you get another year. So within 3 miles, there's a 7-year gap in people. And Crawley is a new town. It doesn't look deprived. But that's what happens in health inequalities. But if you took another bus and went through the other bits, you'd find that there is equal differences within very close communities. So there is a structure to deliver all the aspirations we have. And the aspirations are, if I go back one, but also shows on this side, the blue areas are where the health, where you have deprivation, the yellow is where the rich people live. And when you look at the blue areas, that's Langley Green, Tilgate, Bewbush, Northgate, those areas have number of people, working age adults with long-term conditions. Now just think about long-term conditions. Only 5% of people with dementia have dementia alone. So 95% have a number of other long-term conditions. Diabetes, only 18% of people with diabetes have diabetes alone. So they have other problems. And similarly with heart disease and COPD, they're very similar numbers. That means we're not actually looking at single disease problems, we're looking at complexity. The system has to flex itself to look at complexity, but in the hospitals now we have plumbers, we have joiners, and we have electricians. So if you go in with a heart problem, they'll put electrical stuff up into your heart, and if you have a urological problem. But if you had any complexity, they would say, go back and see your GP. That is wrong. Because we need to have people who can look at complexity and give complex diagnoses and complex treatments and management plans. Okay, so most, for CCG world, the CCG is owned by practices. So it's a membership organization, very different from any other organization we've had up till now. The reason it's different is all the levers are membership levers, not transactional levers with GPs then. So it is for us to ensure that we live within our budget. Yeah. So we have 13 practices, and 13 practices, one GP and a practice manager meet every month, which is called the clinical reference group. And we have an executive group, which has the accountable officer, the clinical directors, the pharmacists, etc. And we have a patient reference group, which has equity of power with the clinicians, because that's the way the new world is. We have to have, so for our contracting meetings, we have the patient there. Never happened before. And so it's very useful to see, interesting to see the change in conversation when chief execs and clinicians talk about money with the patient there. It's a completely different conversation, and it's a right kind of conversation. So there's a triad between, I won't spend too much time because I've only got very little time left, but there's a continuous conversation happening there. And the governing body is to make sure not to vouch for decisions, but to ensure the decisions that are made were made the right way. They can't change decisions. There are only certain things go for decision over there, which is your commissioning plans, your operating plans, the finance bits, and assurance. Those are the bits that go to the governing body. And the governing body will meet only quarterly when we start going, and that meets in public. But as CCGs, we have sick bag full of money, okay? Half of it, and I'll show you in a minute in the next slide, half of it goes to our acute providers, and the rest, 5 is almost 4 are divided equally between mental health, community nursing, medicine management, and there's a CHC, which is continuing healthcare, and there's a small box for others. So that's all the money we have. So when people say, can you get some more money? We cannot print any money. There is no quantitative easing here. So when my acute provider says, I'm overrun, can you give me some more money? I don't have any more money. It's all been allocated. Yep. So when you look at this bit, this is the allocation that goes. So to our Surrey and Sussex Hospital, we give 57.4 million, and that's all we have, because every other pence has been allocated. We're not allowed to provide sandwiches in our meetings because there is no money. Okay. So when people say quip, it is only moving bags of money around, small bits of money around the system. So if we take away from one, we have to give it to somebody else. There is no more money. So in the old days, the SHAs always had a back pocket where they put away 2%, 5% top slice somewhere. So you got the smoothing and corrupting at the end of the year. Every end of year, there was a smoothing and corrupting. So the next year, you were set up really badly because your providers were completely corrupted in their thinking about that, yeah, of course I'll get a bung in the end, but I just have to shout louder. And that's how it worked. And this is just indicative. This is what we have to do for the next 3 years for Crawley of that budget. It's 153 because part of this year's budget is also specialist. And those are the QUIP bits we have to do, or financial recovery. I'm not sure why we call it QUIP. It's not quality, innovation, productivity, and prevention. This is just financial recovery plans. So we have a 2.3, 3.6, 3.5% financial recovery plan. So we have to do something different. And what we're doing differently, or if we don't do anything differently, this is America. Thank God for Obama. I'm so glad he's there. And they will have a health service which will be much more responsive. Because if they don't do anything, by the end of the century, they'd be spending 50% of their GDP on health, and mainly on seniors. And we follow them. So we can't sit back and say, actually, it'll be okay. Only if we fudge it a little bit more, we'll go around in circles and go on another pub crawl next year. That's not going to help because the money is going to tighten up, dementia is going to, we will all need, so we'll have to do something. So the currency has to change. The currency has to, in health, I've sat on boards for the last 12 years, and in boards you always talk about money. It's very rare when it's a token patient involvement. But if we have to have two currencies, we have to have care currency and health currency. We have to do both. It has to be balanced, otherwise it doesn't work. Because the health service is there for health. And what's been happening, this is a really nice photograph, a picture from David Hockney. This is a driver's, this is going down the Pier Blossom Highway, where on this side, this is what the driver sees, and the other side, what the passenger sees. But we're going in the same direction. And that's been happening in the NHS for a long time. The commissioners see one view, the providers see one view, the GP see one view, the consultants see another view. But if we have to do that with the money that is going down, we have to have the same view of what the problems are and the solutions are. And that's going to be a huge cultural change for the NHS. And that's why for us, the only salvation is around mutuality and partnerships, especially health and social care partnerships. In West Sussex, we spent about 102 billion on health and social care, on county-based services, and about the same in health, and the same type of patients. So partnerships, and especially with third sector, private businesses, that's where it is. And we've just won a bid on a dementia-friendly town, where the businesses, the local government, the third sector are helping us normalizing the care of dementia in Crawley. So when people with dementia going for shopping, there's somebody who can help them. I'm almost coming to an end. So this is, we were given a ball to play with after the air was taken out. That's how CCGC, when there was growth, the PCTs and SHs were there. As soon as they hit the buffers, we say, yeah, we must get clinicians in to help solve this problem. And so what we have started doing, and this is what we're doing, is getting the basics right now. We have no aspirations of world-class commissioning, conquering any other continent or anything else. What we want to do is get the basics right. The records in the same place. There's less variation. People are trained up to do stuff. And then probably in about 3 years, we'll be doing the impossible of having real good social health and social care in the money we have. But this is where you guys come in, for me. This is not about pathways of cares, and this is about platforms of care. If you could put anybody in the center, I'll put that lady in there. For her, to get care, she has a whole number of providers, and she has no idea how she's going to get through them. I don't have any idea how she's going to get care at the moment. If you have dementia in Crawley, at this point in time today, and a new diagnosis of dementia, get really poor care because nobody knows which is the best place to go and get care for. So we have to create, for us, is to create a platform where the patient knows, the person knows with their care coordinators what the types of care they are, whether it is statutory and free at the point of delivery, it is delivered by a social care, or it is co-payment. But they know which, and we have to provide that and ensure it's accessible and good. So it's the choice architecture, the nudge theory. So we create the choice architecture as commissioners. Make sure for our population, they have good choice, not unlimited choice, because unlimited choice hasn't worked. There's good evidence for that. So for us, working with pharma, the idea is, say for diabetes, we are overspent by 14%, but the cost of total diabetic care is exactly the same as the next door. But we provide all our care in the community in Crawley. Every GP surgery puts people on diabetes, on insulin, and maintains them in the community. So the cost is exactly the same, but the cost in the community is much higher. That's what we want to do, is move the care out and give better quality of care where the patient has more access. And that is what is happening. So we need to look at total cost. So pharma for us would be looking at the cost of drug is not the important thing. It's the total cost of care that's really important. And the discussion I've been part of with AZ and others have been looking at that bit. Because the old way of working, showing me that the way it didn't work. The other bit is assistive technologies, the telecare, telehealth. There's huge, we have to prioritize because telecare, telehealth, the evidence isn't that great, except when you look at packets of it for dementia, for people at risk, end of life, it really works. Last 2 slides. This is Gandhi. He's one of my idols, not because of his physique or his dress sense, but because he was a great leader and a man of great courage. Courage is something where you put yourself in harm's way for the sake of others. And that, for us as health commissioners, health providers, at this point in time, we have to put ourselves at some risk, some inconvenience for the sake of our patients, otherwise it won't happen. And that is where a lot of my colleagues are now on that journey, to say, what can we do differently? Sure, we have to work a bit harder, we have to attend meetings or work differently. That's where we are. And the leadership and tenacity is really key in that. And he got hit first before he got his supporters there. But with that body and those clothes standing in front of that many women, you have to have courage. At the end, it comes down to Archie again. That's what we hear about. That's what we have to make. We have to make sure that individual patients get a good, coordinated, integrated care. And that's the 5-year plan for us. And that'll take the money out. Then we start creating health and social care partnerships, the joint ventures, the prime providers. There's a whole contracting thing that you can do behind, which we'll speak for a long time. And I hope you'll ask me difficult questions on. But in the end, it is not about populations, it's about individuals. Thank you.